This next speaker is the Chief Medical Officer for Telegen, focused on providing clinical guidance at the executive level and enhancing Telegen's population health management solutions for current and prospective clients. Dr. Paul Mulhausen represents Telegen locally and nationally through his participation in regional and national collaborations. He brings his expertise in the care of people across the healthcare continuum to support Telegen's core belief of delivery of the right care in the right setting at the right cost every time. Dr. Mulhausen received his medical degree from the University of Minnesota, a master's in health sciences degree from Duke University, and completed his postgraduate training at the Duke University School of Medicine. And Amy Bolles is the strategic account manager at Telegen, formerly serving as the health strategist for the American Diabetes Association in Iowa, Nebraska, and South Dakota. She manages the region's advocacy, awareness, and education initiatives, as well as acting as the community liaison to assess the need and drive the mission of the American Diabetes Association. Currently, Amy spends most of her time developing the National Diabetes Prevention Program and has launched the network to support the efforts of the DPPs in the region. Amy graduated from Cardinal Stritch University in Wisconsin and has been a wellness professional over 20 years and has had great success creating community collaborations and relationships to build innovative and creative wellness planning. She is a certified health coach, personal trainer, group fitness instructor, and certified diabetes prevention lifestyle coach and trainer. Amy lives in Waukee, Iowa, with her husband Ted and 3 children, daughter Emma, son Sully, and son Cooper. Please help me welcome Dr. Mulhausen.
You don't know much about me except where I went to school. So let me tell you a little bit more. I'm an internist, and my primary interest has been in aging. So I'm a geriatrician. And I had a practice in Iowa, out of the University of Iowa. So I'm a Hawkeye fan, Cassandra. For about 20 years, and had an active internal medicine practice for around 25 years. And type 2 diabetes is really the core clinical challenge in any kind of general internal medicine clinic anymore. So although I'm not a diabetologist and I'm not an endocrinologist, I feel that the topics that we're going to be talking about here, prevention and self-management support, are well within my wheelhouse. And I hope that you would agree with that in terms of my credibility to come and speak with you. In my work at Telegen, we do a lot of work around health promotion, wellness, and coaching and self-management. So although I don't actually do the work, I do spend a lot of time with people like Amy to help strategize on how we can do things more effectively and where we can be more impactful. So thinking about this problem is something that, again, I hope you would consider well within my wheelhouse. We're going to structure this presentation basically into 3 domains. So I'm going to start, Amy's going to take over, and then I'm going to finish. And it's structured like this. We're going to start out just talking about diabetes. This is nothing new to you. It sets the stage for your conversation today. And the point of it, so listen carefully, because here are my 3 points. The point of it is that it is a huge problem. And there are substantive issues outside of the prescribing of medications that can help our patients with diabetes or those at risk for diabetes. You know that, okay? We're just going to put some numbers to that. The second part of this, we'll be talking about the Diabetes Prevention Program. You, I expect, know more about the Diabetes Prevention Program than I do in terms of operationalizing it. Amy knows way more about the diabetes prevention program than I do in terms of how to operationalize it. The insight that came to me was, why aren't we doing this where the people are? And where the people are, at least in my adult world, is at work, sadly, all right? So why aren't we doing this more in the workplace? And the thrust of that conversation is, look, it's an effective strategy. Look, it can save money. Why aren't we actually reaching out and providing these kinds of services for diabetes prevention through workplace wellness programs? And then the third part of this conversation, so point 3, is that for anybody who has diabetes, whether it be type 1 or type 2, if you look at chronic illness models and say, what in all this really works, and you ask the people who have spent a lifetime studying them, I believe I have stumbled onto the theme that works, and it's only one of several, but it's one that comes up over and over and over again, and that is, these don't work without effective self-management support. The client, the patient, the beneficiary, the person we are trying to help has to take over their illness for these models to work better than coming to see me in the clinic and say, hey, why don't you take Actos, right? Okay, so the thrust of that is, why aren't more people doing this? And I think we encounter the same barriers that we encounter with diabetes prevention. It's a big pain, it's time consuming. You gotta put some energy into it, and I gotta go home and feed the kids. So again, why aren't we reaching out and doing this more in the workplace? So the thesis is, diabetes is a big problem. We can do things both to reduce the burden of illness as well as save money. Diabetes prevention plan is a known strategy. Amy will talk about the money stuff, but there's pretty good evidence that it can save money. Why aren't we doing this in the workplace to make it more effective? And that diabetes self-management and self-management training and support are essential to optimal management of both type 1 and type 2 diabetes. Not enough people take advantage of it. Doing it in the clinic setting has its own set of barriers. Why aren't we doing this in the workplace? I can quit now if you want. No, I won't. Because now I got to show you all the pretty slides we made. All right, so we've set the stage for today's conversation, I hope, and you have a reasonably good understanding of what Amy and I want to accomplish in this presentation. And you are welcome to fall asleep, because you already know the point of the presentation, which is exactly what I wanted for you at this point. All right, so let's start out with what I said would be the first section, which is, this is a bad problem. This is a big, bad problem. So what we're going to do is we're just going to contrast the numbers. So the numbers are impressive. They're just numbers. I don't want to spend a lot of time reading numbers, so watch the slides. It hits home how bad the problem is in Iowa, how it's even worse across the nation, and it's not getting better, it's getting worse. All right? So these are Iowans. There's over 300,000 of us who are living with diabetes. And there is, 3 times that number? I know my math isn't very good, but a lot more people who are pre-diabetic for whom their diabetes prevention program might actually be of relevance. And this is a super expensive problem, even in our own state. So we're talking about $2.5 billion spent on diabetes and the complications of diabetes. So this is not a small problem for the people of Iowa. And your effort to find common ground and pursue your mission is of huge value. If there was ever a time to be focused on diabetes and trying to change the trajectory of population health impacted by diabetes, it is now. So here are the numbers. So you can see there's the total population over the age of 70, and that you can see that that 8.3% of those people, or 8.53% of those people have diabetes, and that it's worse across the nation. How many have looked at those maps on the CDC website for the prevalence? And you see that swath of dark brown orange that goes across the South. All right, that's the real crazy diabetes belt. And that's where I used to practice, right, in North Carolina. So I know it from that world. And in Iowa, we're catching up, and we're following the same trends. We're doing a little bit better. You can see here, this is a breakdown by gender. We talked about the 8%. So you can see that the percent of men with diabetes, the percent of women with diabetes. Again, we're talking around 8%, and it's worse across the country, illustrating that point. If you look at Medicare beneficiaries with diabetes, it's 23%. So remember, I'm a geriatrician. My work is in Medicare. I said the central problem that you work with is type 2 diabetes. So 23% of the beneficiaries. So I used to teach at the College of Medicine at the University of Iowa. And my task was to highlight, you need to learn diabetes. And I did it in a different way, but I'd show that, if you end up in this county in Iowa, 1 out of every 5 people has type 2 diabetes. And they got to go to the doctor, which means your practice, whether you're taking care of them as a surgeon or as a primary care physician, you are not going to escape this particular disorder. You need to know about it. So when I tell you this dominated my life, this is utterly true, and it's rooted in this statistic. And then the other thing is just when you think about, you'll probably all spend some time thinking about workforce issues, but one of the challenges that I thought we faced in primary care medicine was actually this recognition among medical students that what they would be doing is not just another service I got to pay for, right? It becomes a financially impactful preventive program. And it is, and honest to God, if you spend a lot of time thinking and talking prevention, it's very difficult sometimes to connect the dots around savings. But here's one where you actually can start to connect the dots around savings. You invest now, you're going to save money later. And so the costs are huge. So we're talking about, in the last 5 years, a 74% increase in the cost to $44 billion. I mean, it makes your head, explode. So it's a common problem. It's impacting everybody in healthcare. It impacts a lot of our patients, especially those who are getting older, where 1 out of 4 have them, and in some places 1 out of 5. And so it's a big deal, and spending our time today talking about it is worth it. So that's the first third of our presentation, and I'm going to let Amy take the podium and the floor and move on into our second.
Well, Dr. Call is a hard act to follow. I'm not as dynamic of a speaker as he is. We're going to talk about diabetes prevention in the workplace, and I think I've spoken on this topic a lot of times in front of many of you in the room. So I wanted to mix it up a little bit so that we're not always talking about the same old thing. So again, we are really going to focus on prevention efforts in the workplace. We are going to talk about the diabetes prevention program specifically, but we're also going to talk a little bit more about how prevention can take a little bit of a different model. It doesn't always have to be the diabetes prevention program. So some fast facts. Workplace stress leads to unanticipated absenteeism, costing companies about $600 a worker a year. People who are physically active for about 7 hours a week have a 40% lower risk of dying than those that are less active. And the annual medical costs are about $1,500 higher for individuals with a BMI value over 30 than those at levels under 30. Those are fast facts that we use when we're talking to workplaces to really help them put in strategies in place for really chronic disease prevention, but specifically diabetes. We know studies around the diabetes prevention program, around other prevention efforts show that individuals that participate in a structured lifestyle change program can cut their risk of developing type 2 diabetes by more than 50%, which is huge when we are talking about looking at the growing costs of type 2 diabetes. So it really builds a case for supporting those prevention efforts in the workplace. We really know that there's not a one-size-fits-all for everybody, and that's why I love the diabetes prevention program. I train on the diabetes prevention program. I think it's amazing, but again, it is not a one-size-fits-all. So when we are meeting with workplaces, we really do have to understand the demographics of the employees that we have. Are they at their desks? Are they in transportation, which is a huge group that actually has huge issues of type 2 diabetes, because truck drivers, sanitation workers, all of those, they don't have the luxury of being able to take breaks and get out of their vehicles. So that's a huge growing concern group. They're not necessarily going to be able to handle or be able to participate in a structured lifestyle coaching program the way that we know it. So we really have to be able to look at multifaceted programs as well as delivery models. We have been working with delivery models. Telehealth is amazing. Working with mobile phones are great. We really have to be able to be non-traditional on those. We know that obesity, nutrition, and physical activity programs in the workplace are critical elements in addressing type 2 diabetes. Again, we need to get creative with those. How are those going to look in each of those organizations? And we do know that, again, the research suggests that the progression from pre-diabetes to type 2 diabetes can be prevented or delayed if we can find those programs that are going to engage those individuals. The lifestyle intervention works equally well for men and women and for all racial and ethnic groups. Again, the intervention itself works well. We just have to really be able to analyze the delivery model to be able to apply. So, and also the ADA recommends that people with prediabetes should be counseled on lifestyle changes with goals similar to the DPP. So the diabetes prevention program is actually, just like Dr. Paul said, it is really, really well suited for the workplace. We want to meet people where they're at, and people spend the majority of their day at work. If you think back to yourself personally, what are you doing when you go home from work? You're either running kids around or you're exhausted from your work day. You're not necessarily going to go and engage in something for yourself. So if we can meet people where they're at, that's going to be more successful. So diabetes prevention in the workplace makes it easier for people with prediabetes to participate in that evidence-based program. It also can really be reinforced when it's engaged and tied to a wellness program. So if we get those corporations that actually have a wellness program where they're doing biometric screenings, we do not ever want to supplement the doctor or the physician. We want to work alongside. With programs in the workplace, we are actively encouraging them to go take their results to their physicians so that we can partner with them and be an accountability, because when you think about they go and see their doctor for 15 minutes, maybe once a year. Here we can actually go partner along with them in that workplace wellness program and really have more of an impact. As well as when we have the diabetes prevention program in the workplace, they also have that peer support. They're not alone. They have that group that they're engaging with, so they can actually see them at the workplace. They can reinforce maybe not going to that potluck on Friday that's full of all of that stuff, or maybe they can band together to try to impact and bring healthier foods to that potluck. Again, diabetes prevention program is just one way to do it. We do also want to look at different delivery models of the diabetes prevention program. We have been, the CDC has been actively working with a distance learning model, so you can actually do credentials around that. And that's really a way to take a classroom setting and use HIPAA compliant web broadcasting ways so that you can actually do different locations, or people that are traveling can actually be able to partake in that. And we've done a lot of work with sampling that out and how that's going to work. So if you have any questions after this, please feel free to talk to me. I've been in demo stages with Skype and Zoom, and have a lot of good insight on things you can avoid if you're trying that out. But there are other ways. Again, we want to make sure that we are capturing those people that maybe don't want to do a peer support. They don't want to be in a group. They really want one-on-one. And that's where we can really do at-risk coaching as a really good model to help. The thing about the diabetes prevention program is the curriculum is available on the CDC website. So if you have coaches that are coaching to that prediabetes, they can actually access that curriculum and be able to do it one-on-one. So the delivery can be completely different, doesn't have to be in that group setting. One of the examples of a diabetes prevention corporate program is what we've done with the American Diabetes Association Intelligent. And I was actually very, very fortunate. I used to work for the American Diabetes Association and started working with Intelligent to be able to develop a corporate program. And here I am now with Intelligent, but it's been awesome. We have had a lot of success with working with companies that Intelligent was already engaged with and doing pilot programs of the diabetes prevention program. It has been, again, we follow the same CDC year-long structured program. We are actually, like I said, we've been doing some distance learning, which is really great, so we can actually take organizations that have different branches and we can bring them all at one and do it at the same time, which is very cost-effective, and they don't have to pay for numerous coaches and numerous locations. It is still facilitated by a trained lifestyle coach, and we do use the CDC-approved curriculum. We have regular opportunities with direct interaction between the lifestyle coach and participants. Even if it is not on site, we have some really, technology is a wonderful thing. And so we have lots of email works for chats. We've developed Facebook private groups for everyone to chat with each other if they're not in the same location. And it's really worked. And really, again, that diabetes prevention program has that emphasis on behavior modification, managing stress, and peer support. One of the nice things, too, is that with some of the companies that we do work with, they have a wellness program in place, so they incentivize the diabetes prevention program, whether it's that they need to take it to receive their premium differential, or if it's just paid for and they're really highly encouraged, they get points for a points program. But then the other added element is that some of these individuals have biometric indicators where they need at-risk coaching, and what's really great is we've seen these programs where they're in the diabetes prevention program and they're doing at-risk coaching. And those coaches are talking with the lifestyle trainers, and it's additionally supplementing, and it's really great to see when they screen again for biometric screenings, the reduction and where they're at. So, and that's another nice thing I would say about a corporate wellness program with the diabetes prevention program. When we're looking at the fact that CDC is benchmarking it at a 5 to 7% weight loss, within a corporation that's doing biometric screenings, we can actually be able to tie it directly to lower blood pressures, to lower A1Cs or lower glucose, which I love the CDC and I do not want to talk badly, but I think that's a higher level to hold people to and see a success rate when we're actually looking at those markers. Why will companies invest in prevention? I love to say it's because it's the right thing to do. And that's what I always want to tell everybody, because I'm that idealist that says it's the right thing to do. However, we know that companies are probably going to bite at it first because it is going to be an investment. It's going to save them money in the long run, and it's also going to save them money and productivity with their employees. So we do see that companies typically see a cumulative and net savings over a 3-year period, and I think most of you probably know this site, but if you don't, the AMA cost calculator is a great one to have on your laptop or on your phone bookmark to be able to look at that. So we hope that we can get everybody in prevention programs and really ward off the diagnosis of type 2 diabetes or really prolong it to where they're at a very old age. But unfortunately, we know that as it trends, it's not necessarily going that way. So Dr. Paul is going to talk about self-management.
That 3-year thing is really important. So if you're a human resources person, you're sitting around thinking about your health plan benefit, you actually have a rationale for not investing in prevention that's going to have an impact when the people who work in your setting aren't there anymore, right? So that's a relatively short turnaround time for return on investment. And that 3-year number in my mind becomes very valuable in your pitch. Because if you say, oh, this is going to help them when they're on Medicare, so, right? Okay. So anyway, that I want to highlight that relatively short benefit time that Amy has pointed out to us. All right, so I want to talk about self-management support. Now, how many of you are like certified diabetes educators? A lot of you. What are the rest of you? Just interested parties. Okay, so when I think this through, I imagine a lot of you do this well. And you may be thinking to yourself, we do this well, don't make it more complicated. And I'm going to argue that this isn't about you doing it well. I'm not here to teach us how to do self-management support, especially since I probably can't teach you that. I think I did it well, but the numbers share something, and that is that maybe we are individually doing it well, but when it comes to the breadth of this problem, our impact is tiny. So, so that's really why I want to highlight this way to think about expansion and penetration, broadening impact. Again, one of my jobs at the medical school where I used to work was I was a chronic disease doctor, and so I felt obligated, because I had control of some curriculum, to be introducing young physicians, growing physicians, formative physicians, to this whole notion of chronic disease and the way it's going to change who you're practicing with and how your practices are, and ways to do it better. And I actually helped to develop a curriculum on motivational interviewing. Cassandra was talking about her expertise in motivational interviewing. And you know that in a 2-hour lecture to medical students, they're never going to become mint-level motivational interviewers, right? So the question came to me this was years ago, so she's not a recent grad anymore, she's a practicing doctor. But she was a recent graduate of the medical school doing her residency in Iowa, and we were both at a conference talking about chronic disease and chronic disease management, and it became clear to her that the people talking were part of a team, and that the people who were talking motivational interviewing were not the physicians. And she came to me and said, why did you spend all of my precious time telling me about motivational interviewing, blah, blah, blah. We're never going to do it. Continue to come to believe that it's a skill set of value to physicians. And I happen to have the really good fortune of going and meeting Ed Wagner, who is the godfather of the chronic illness model of care. And we're going to show you a version of his model. And I posed this question to him. And he thought it was an interesting question, but he also thought it was kind of missing the point. His point was that the medical community, the physicians in our world, are still sort of the authority figures on the team. And if the head of the team has no idea about the tools of the rest of the team can't be effective. And that was the nugget of gold I needed to keep pushing that program as part of the medical school curriculum. So I have a lot of respect for Ed Wagner because I think he really understands the team, the chronic care management model, and quite frankly, he is the person who literally taught me, without self-management support, the model falls apart. Okay? Interventions that encourage people to acquire self-management skills are essential in chronic illness care. So again, if my thesis is true, the only challenge we face is how do you make the people who are doing the self-management support an effective member of the team. And that's a logistics problem and a culture challenge. But it's not insurmountable, right? It's not a knowledge-based problem. It's not, it's how do we figure out how to work together? And that, I think, is actually a huge challenge. I don't want to minimize it, but that really is the task to think through. So I wanted to, I started out saying I think you probably do it well, and I think I did it okay. But here are the stats. So despite us doing it well, these are the things that you go, really? That's unbelievable. Half of the people who know they have blood pressure do not have it under control in alignment with clinical guidelines. And I made this slide before this week, so it was the old blood pressure guideline, all right? So, and actually you'll see that's the statistic from a Health Affairs article in 2001. But the numbers still hold, and actually Medicare asks Telligen to try to help people, help clinicians with that. But half of them, so they go to a provider, they're told they have high blood pressure, the provider knows they have high blood pressure, and yet they're not under control. A third of the people with ischemic vascular disease who have an indication for life-saving aspirin therapy are not taking it. A third. Now, this affects me personally because I'm a part-time primary care doctor, and as a part-time primary care doctor, I basically see bronchitis and sinusitis and people who just don't feel good, right? And it's fascinating when you think about this, because I get so obsessed over what can I do about your cold that I don't prescribe the aspirin. Their cold is going to get better whether they saw me or not. Their aspirin could save their life. Something has gone wrong. Fewer than half of the people presenting to a healthcare provider with depression or anxiety receive appropriate treatment. Now that's depressing. Fewer than half the people with asthma. So I know this isn't diabetes specific, but it really does illustrate the challenge we face when we're working with people who have chronic illnesses. Now you can't see this slide, and how many of you have ever seen the sort of traditional infographic of the chronic illness model, chronic care model? And it looks like a big spaceship, right? Well, because I work at Telligen, and that image is proprietary, I can't use it, sorry. So this is a sort of schematic of Dr. Wagner's model. And you can't read it, but there are two places in there in this model. So one is in the team and one is in the patient, where it highlights the key to self-management. And I know this from my own practice, and you know this from your own work, that your patients who figure it out because you helped, well, not because, whether you helped them or not, but hopefully we help them figure out, really do a better job. And you know, so I have to share this story out of my practice. I worked with they were younger than me, a married couple in their 40s. And the wife, who was my patient, had type 1 diabetes and had a terrible, disabling time with glucose management in her type 1 diabetes. She was disabled essentially from recurrent hypoglycemia. She'd been to Rochester, Minnesota. She had seen a whole slew of diabetologists, and through just bad luck in life, ended up in my hands. But here's where it got interesting. And it got interesting because she and her husband and I, in my opinion, became a team. And her husband and she took control. And rather than just doing what was being told of them and coming back and being told and coming back and being told, they actually started to be proactive. They finally had, and again, this is not about speaking about me. It's speaking about a process. They finally had someone, when they gave the notebook of the blood sugars, they looked at it. Okay? Because up till then, it was like, well, nobody seems to care. Why are we doing this? So there was a sense of engagement. And as they took control over management of their insulin regimen and their glycemic control, she managed to stay out of the hospital. She moved home. There were just a lot of really nice, good outcomes that came out of that whole experience, and seared into my eternal memory, which will die someday, so I guess it's really not eternal, into my memory that this works. Self-management, support, and self-management works. Okay, so now you say, well, we're so much better at this in diabetes. And some of this I agree is hard. 16% with an A1C over 9, I go, how bad is that? But, it's a pretty substantial number. But 60% not doing their eye exam? I mean, really? It's not that hard, okay? So even though we may be individually doing this effectively, there's still a lot of evidence that in the comorbidity management, in the preventive interventions like losing weight and getting physically active, we could penetrate our work a lot better. So the other point I'd like to make here is that, and you may know this better than me. For me, this was an enlightening kind of moment. Self-management in diabetes is not diabetes management. Self-management in diabetes is both diabetes self-management as well as managing their lives with diabetes. And that managing your life with diabetes, in my mind, ends up being a key concept. Because in it helps to frame the opportunity of doing this kind of work outside of the healthcare environment, right? So it's less about managing my disease and more about helping me live a life despite the fact that I have diabetes. And then I hope my little story illustrated the potential for partnership. But there are lots of things that get in the way of doing this well. So insurance coverage gaps are a big one. So last year I gave a talk at a conference and I didn't have to speak first. So I got to listen to what everybody said, right? And I quickly caught on to something. And it was, we do diabetes prevention, but nobody comes. Okay? And that's what I mean by suboptimal clinical service design. All right? So you set it up. Physicians may or may not make the referral. There's your first barrier. The linkage isn't established to get the person from that clinical referral, if it's made, into the program. And then there are just sort of the geographical life barriers that come into play. So suboptimal clinical service design is a huge issue and allows you to think about it in, well, if either how do we redesign the clinical service if this is our role, but even more interestingly, to think about how to do it outside the clinical service model. The patients are always central to things that can sometimes be a barrier. The disease itself. There are lots and lots and lots of studies that show that we physicians sometimes just aren't very good partners. So that's a big part of it. And then, of course, socio-environmental context. You probably are part of a group of thought leaders who think carefully about social determinants of health, and that becomes important as well. And again, I would make the argument that for many of us, thinking about doing this in the work setting with an enlightened employer could be a way to mitigate the barrier from socio-environmental context. And this is too sensitive. Okay, so I'm making I'm putting forward the thesis that thinking about diabetes self-management and diabetes self-management support can be thought of as an ecological model rather than a pure healthcare delivery model. And that for us to be as impactful as we can be, we need to move beyond what we're already doing en masse. I'm sure some of you are doing some things very innovative, but the clinical service delivery model has been left us wanting, okay? So taking this in the context of a broader ecological approach, I think is certainly a good thought exercise and one to consider how to operationalize. So this is just an infographic schematic diagram that I thought was nicely illustrated both the essential elements of self-management support and this ecological model, and how you can get these various levels of essential key elements, individual assessment, collaborative goal setting, enhancing skills, follow-up and support. You get it? You see that all on the right? And how you can envision people pursuing self-management expertise, getting those things outside in this ecological model. And again, I think that becomes very important, because now I want you to stop and think about work. Because again, part of my presentation goal is to get you to think about where else could we be doing diabetes self-management training and support. And I think that many of these elements can be gotten in the workplace. So this, again, just another schematic to illustrate that ecology. So if you think about doing self-management support in the workplace, the opportunity is that it broadens the access and appeal to adults with diabetes, right? So you could actually provide them a curriculum that helps them better understand the illness, better understand how to live a full life despite the illness, and help them better understand how to be more proactive partners in the management of both their lives and their diabetes. There are, and again, you guys know this better than me, but I'm just trying to connect the dots. So there, these standardized diabetes self-management educational curricula that are out there already that could be applied in these settings. So the DEEP program is one that I actually know very well. And the Stanford program I know from my days in the College of Medicine. So those are two validated, Health and Human Services approved curricula that could be applied in workplace settings. And beyond that, Amy talked about in diabetes prevention programs, there's a whole tool set that could be applied. And there is evidence that individualized health coaching and telephonic health coaching can be impactful in terms of glycemic control. So that's the outcome of interest. But that's probably enough evidence to say it works, and I think gives rationale to say, health coaching in the workplace should be a potentially evidence-based, potentially effective, if not actually, there's evidence that it works in the workplace as well. And then technology support, and as Amy has pointed out, the literature is evolving on the effectiveness of using internet-based, web-based learning tools to help people with self-management. So there are a lot of things that could be done that, in my opinion, are from a curriculum perspective, low-hanging fruit. You could go out there and do the DEEP program probably tomorrow. I don't know who you are. But my bet is you're a smart, informed person who could do this. I could do it in a week, okay? I could go do it. I'd have to do my week. I'd do a week of homework, and then I could go do it. That's not the hard part, right? The hard part is thinking through how do you make this part of the team, and how do you get some buy-in from the people who are in control of the workplace. That's the hard part. So, huge opportunity, if you think about it, to consider, am I going too long? There's a lot of activity here. You're going to kick me off the stage? So there are a lot of barriers that impede the potentially broad impact of your skill set that you bring with diabetes self-management. I'm a part of this, we need to be taking this ecological approach, which means we need to think hard about getting out of the hospital, out of the clinic, get to where the people are with diabetes, and help them learn how to manage their illness in their lives. The model implies that the workplace could be a good place to do this, and you already have the tool set. I'm not saying it couldn't be better. More power to you if you build a better mousetrap, but the mousetrap you have works. And if we start to think collectively about how to move it out of the healthcare environment into, in the spirit of the sort of ecological vision of self-management and self-management support, doing it in the workplace presents an opportunity to sustain that work, right? So just in summary, I should summarize, shouldn't I? So it's a big problem, and it's costly. Prevention can save money. We know self-management training is essential to effective life and disease management, and there is evidence that it helps to save costs in terms of complications, but in all honesty, it's a down-the-road sell. Down-the-road sell. So, but all of this implies that there is an incentive for people who are buying health plans. For most Americans, that's their boss, right? To be thinking about doing this in the workplace.